My name is Dr. Frank Vicini. I'm a radiation oncologist. I work for PrecisCa and Michigan Healthcare Professionals in Michigan. I'm a breast cancer specialist dealing with primarily clinical applications of newer forms of radiation therapy and, of course, clinical trials in breast cancer research. Patients who have biopsy-proven nodal disease at diagnosis who then undergo neoadjuvant chemotherapy and are found at surgery to have a complete or partial response pathologically, the decision to treat with radiation therapy to the axilla and the regional lymph nodes is individualized based upon a lot of data that we've collected over the years and in a couple of phase 3 trials that are undergoing right now. Again, the patients who undergo a complete pathologic response to neoadjuvant chemotherapy have been shown to have excellent outcomes. There have been multiple published studies showing this. Although most of these trials were not designed specifically to address the issue, meaning they were not looking at specifically omitting radiation therapy to the axilla in complete pathologic response. What we've seen is that the risk of axillary failure in these patients is extremely low. And because of that, we now have a couple of phase 3 trials designed specifically addressing that issue. Specifically, NSABP B51 was specifically designed to look at whether or not patients who undergo a complete pathologic response at surgery require any type of axillary radiation therapy. And so currently in patients with biopsy positive lymph nodes at diagnosis and undergoing a complete pathologic response, I'm one of the co-PIs on the trial, so we recommend patients be enrolled, if at all possible, on that study. If not, certainly the radiation oncologist can decide individually whether or not a patient should be treated along the guidelines of that protocol. But specifically on B51, if a patient undergoes a complete pathologic response to the lymph nodes, if they've had a lumpectomy, they're randomized to either whole breast irradiation without treatment of the axilla or same whole breast irradiation with treatments to the regional lymphatics, including the axilla. In patients who've undergone a mastectomy and had a complete pathologic response in the axilla, they're randomized to either no radiation whatsoever, neither to the chest wall or the regional lymphatics, or to comprehensive regional nodal radiation therapy, including the axilla, the supraclavicular fossa, and the internal mammillary lymph nodes. Certainly, if patients undergo a partial response in the axilla, at this time, the standard is still provide a completion axillary dissection, but in some cases, those patients are treated with radiation therapy to the axilla. The important consideration in all of these patients, of course, is what is the additional morbidity from the radiation therapy that is given. Well, again, fortunately, through better and better techniques that we've developed with radiation therapy, we're able to reduce the doses to the lung, to the heart, and certainly by tailoring the radiation therapy based upon the extent of the axillary surgery, we can even reduce the potential long-term morbidity to the risk of lymphedema. But we also take into consideration other factors off protocol in those patients undergoing a complete pathologic response. Again, we take into consideration the age of the patient. The younger the patient, the more likely we are to recommend comprehensive regional nodal radiation therapy. Certainly, we look at the tumor size, the initial tumor grade, the histology, the molecular subtype. All of those things are taken into consideration in those patients who are treated off protocol when they have a complete pathologic response to the axilla. Again, because we are able to reduce the morbidity of our techniques, we are more likely within the past 5 to 10 years to offer radiation therapy to those patients in this setting. But nonetheless, this needs to be taken into careful consideration, considering the importance of reducing long-term morbidities, but also to improving the overall cure rate of the patient by reduction in axillary failure or any of the regional lymphatics.